That's illustrating basically one of the cases we had this year. I'll try to. All right. So I don't know which one, but both at the same time it works. So 65-year-old female with hypertension that's referred for a non-STEMI. She has her first coronary angio, which is normal. It goes back to the CCU, but 1 hour later, she has recurrent chest pain and new AV block. She returns to the cath lab, and there's an RCA dissection that gets stented and is open. An hour later, still in the CCU, she goes into VFib, has CPR, one shock, and then she does okay, and the ECG is normal. At that time, an echo is done showing mild or moderate RV dysfunction.
Was the RCA dissection caused by a catheter during the, do we know the mechanism?
That's what was the assumption. So she had normal coronary initially, but they thought probably the catheter might have started the
So as a surgeon, you blame the interventional cardiologist?
I always blame the interventional cardiologist as a rule, but in that case, the interventionalist blamed himself. So I didn't have to do anything with it.
Self-hating intervention.
Was there evidence on the angiogram of that? So
when we look back, there was a suspicion, but it was a very mild dissection, and most people that looked at it, because obviously those cases get a lot of
there's no chance it could have been a scat or something like that.
It's probably not.
Okay, surgeon, you may proceed.
We didn't proceed much at that point, but this is the echo, and you can see on here that the left ventricle is not that bad. Same thing here on the short axis. But the right ventricle is dilated. Mm-hmm. And she goes into progressive shock. And a few hours later, we're in a pretty bad shock situation. And we end up needing to support her with an RVAD. The lactates are going up. She is more and more unstable, and the interventional cardiologist calls me to go in together and support her. When I evaluated the patient, she had norepinephrine at high doses, epinephrine at high doses, lactates ramping up. It's 9 o'clock at night. So we decided to go in with a relatively simple system with a drainage cannula in the coming in from the left femoral, going all the way to the upper vena cava, and an outflow cannula going from the right groin to the main pulmonary artery with a pump in the groin connected to those two cannulae.
So is this a Centromag or what is it?
The pump we used in that specific case was Tandem.
Tandem.
Yep.
Protect Duo? No, it's not the Protect Duo.
No, it's just regular cannulae,
tandem.
but the pumps.
Two tandem. Well,
only one tandem,
LV,
two cannulae.
Regular LV type tandem. Yeah.
Exactly. So for this case, it was relatively simple to go park a stiff catheter in the pulmonary artery from the groin, and another stiff catheter from the other groin in the upper vena cava, and then get the 25 venous up the SVC and the 19 outflow in the pulmonary artery. This is all heparinized, and we started the device.
So at this point, you have the strong impression that the RCA is still open, patent?
At that point, the impression was that the RCA was still patent.
Okay. So did you have an idea as to why the patient was undergoing shock after such a short term of occlusion?
The occlusion caused some RV dilatation, and despite having the RCA open, there was the impression that there was some stunning and significant injury. So, and the systemic effect was that numerically the cardiac output was not that bad, but there was pretty bad dysfunction. On the next echo, this is aortic valve short axis where you can see that the cannula is going here in the main pulmonary artery. And one of the more important things when we install those RVADs is to make sure that the outflow is not below the pulmonary valve, which obviously wouldn't make such a great RVAD device.
No, it wouldn't.
Okay. So next we looked at the SVC here,
Proximal, doesn't it?
and you see in the bicaval view, IVC, SVC, and this is the large 25 French venous drainage cannula. That's a standard surgical cannula. And then we looked specifically at wall motion abnormalities on the left, and there was an inferior and inferolateral dysfunction with significant mitral regurg. In that specific case, we didn't think the mitral regurg was a huge problem with forward cardiac output. The left ventricular outflow tract VTI was not very bad, but we thought it might be helpful to add a balloon pump to decrease the afterload and decrease the mitral regurg.
So you raise an interesting point. Whenever you have shock, it's very rare that you would only get pure right-sided shock. There's always, a little bit of left shock as well. Is there a risk with right assistance that you will overwhelm the left ventricle? Has it been your experience in pure or presumably pure RV failure in where you assist them with a very powerful device? All of a sudden, they go fine for 10, 15 minutes, and then they end up crashing from the left system.
Yes, we've seen that. So this is one of the reasons why I always say be aware of the normal ventricle in the right ventricular failure, of the normal LV, because, like you said, it's exceedingly rare that we have an infarct that affects purely the right ventricle and doesn't really do anything. So whenever I have a patient who has an LVEF of 40 with a bad RV, I think the patient is
You call
gonna
this a
need something.
biventricular?
Yeah.
Huh?
The case I am presenting had only heart as the major problem. Shock was getting pretty deep, but there was no major organ dysfunction elsewhere. So we had to look at both ventricles and decide which was the main problem. And clinically, it was pretty obvious that the right was the most important problem for that patient. But the left ventricle was was not normal, and the mitral regurg was an issue. So we put in that balloon pump, hoping not to have to go on to full ECMO for that patient. In that case, if I had to go on full ECMO, I had already an introducer sheath in my right femoral artery. So that was an easy conversion from my RVAD setup, just putting in an art line and transferring it to a systemic ECMO, systemic VA ECMO. So this is the balloon pump going in. On the right here, you have two cannulae, the exit of the pulmonary artery cannula. And that's what the hemodynamics did. So norepi went from 0.8 mic per kilo per minute to almost 0.2. Epi went from 0.45 to 0.08 in the minutes following initiation of the support, and we could stop the vasopressin. Next morning, there was no organ failure. Hepatic enzymes were normal. Lactates were normalized. Normal renal function. We could remove the balloon pump at 48 hours with moderate MR. And we removed the tandem at bedside on day 5 with just one stitch at the skin because it's venous, so it's low pressure. We did a TTE on day 10 with showing a left-sided EF of 45, MR 1 to 2, and the right coronary had, or the right ventricle had recovered with a TAPSE of 19. And we did another angio to answer Marc's question. So left main LAD and circ were normal. There was a flap in the PDA, but everything was open. But then there was a dissection in OM1. So we thought, okay, that's an abnormal patient, and we didn't caused this first dissection on the right. So she had medical treatment for the dissection in OM, and she was transferred back 14 days after arrival in a very good clinical situation. So the key points of that case was we had to identify the patient early. From the get-go, we knew the patient wasn't an easy case. She had a dissection on a previously normal RCA. That's at risk for developing shock. We went very early on to ramp to max support. So we went to moderate dose inotropes, mechanical ventilation, inhaled nitric, and despite that, she deteriorated quite early. The whole team was mobilized early so that we knew what would be our next step if she didn't behave normally with medical treatment. We had Q2H lactate and blood gases, and as soon as we saw the lactates ramping up and the bicarbs going down, we knew that she was not going in the right direction. So we went to a VAD before any organ dysfunction occurred.
Remind us what was her age?
52.
Wow. Could it be a case of fibromyalgia? I've never seen any, but I don't know. Has it been raised as a possibility?
We didn't do a biopsy in her coronary.
No, but whenever you touch the arterial walls, they will dissect, or because obviously she was not pregnant.
Everyone was very
it's one of the
worried
rare
that she had
disorders.
abnormal coronaries.
Anyone in the room with experience with FMD? No.
I mean, I sent her to the cath lab the second time because she complained of chest pain again. And I wasn't sure what was going on. Everything was out, the device and whatnot. So I sent her to the cath lab thinking, well, I don't know. And then they called me and said, it was unbelievable. We didn't think we would find anything. And she had a dissected ramus or a big OM or something like that. It was just, and they didn't instrument anything that much. So I think she had a predisposing either an element of spontaneous coronary dissection or there's some abnormality of the native tissue itself. So it was a bit bizarre.
That was certainly a bad day for the interventional cardiologist, I can tell you that.
Well, everyone ended up doing
I
fine.
still am not sure. I mean, it'd be nice to see the films, but I don't know that this wasn't SCAD.
Yeah.
Yeah.
Yeah. All right. You want to go ahead with one case of? Yeah. Okay.
So while we're doing that, I'll just tell you of the case that I had when I was a fellow in Michigan, and then somehow the same case came to haunt me at McGill when I came back. We had a young woman who was 30, several weeks postpartum, who came with chest pain and raised tropes and anterior ST elevations, who actually ended up with a true spontaneous coronary dissection, and then during instrumentation ends up arresting, first VTAC and then a full arrest from which we couldn't get her back. And at 15 minutes we initiated the ECMO code in Michigan, which took us to about a 50-minute mark to put her on VA ECMO in the cath lab. And interestingly enough, she actually survived neurologically intact. And then a few months ago at the cath lab at McGill, we had exact same case where another young lady came at a similar situation and had exactly the same thing happen to her.
And she survived?
And she survived too. So this is a case of a 51-year-old woman who was 6 years post orthotopic cardiac transplantation for dilated cardiomyopathy. She was quite a medical textbook, actually, in terms of comorbidities. So she came to us 3 days with a 3-day history of breathlessness and fatigue. And was really looking poor when we examined her. So she was desaturated. She was hypotensive. The lactate had already been 6. She hadn't peed much for hours and just looked god awful. So she ended up intubated with standard lines and rapidly increasing doses of vasopressors. The echocardiography demonstrated diffusely hyperkinetic LVEF with an the LV with an LVEF estimated about 10%. Her RV was small and was only mildly hypokinetic. She had quite a bit of TR and MR. We proceeded to put in a Swan-Ganz catheter, which showed us that she had a cardiac index of 1.3 with a mixed venous saturation of 40%. Chest X-ray was pulmonary edema. Very soon after, she actually ended up on Costco-style doses of inotropes and vasopressors. And we ended up going for a cardiac biopsy because the presumptive diagnosis was acute rejection. At which time we inserted a balloon pump. This actually eventually ended up being a 3R rejection. And she had received pulse steroids immediately on arrival. So here we were with a lady who was 50, who was a bit of a medical mess, but who had religiously taken her tacrolimus and MMF or whatever she was on. I think it was exactly that. And who comes in with a 3R in context of previous normal biopsies per Stanford protocol. And we were now dealing with somebody in profound cardiogenic shock with multi-organ failure. Her LFTs had already started going up. Her creatinine was through the roof. And like I said, we were hydrating her with norepinephrine, adrenaline, vasopressin. We also added some balloon pump for giggles. But that didn't get us anywhere. So we were faced with what to do with her. And of course, ECMO was brought up, and especially in the context of pulmonary edema. Then we had some discussions and decided to actually go with, we debated whether to put a uni or a biventricular support device, and we chose to start with a percutaneous, or in this case actually it was a cut down because it's a 5.0 Impella LP system, which allowed us actually to offload the LV enough to allow for some of the septal shift and recovery of the left ventricle without ever a need for right ventricular assist device. So this is actually some of her data. The first arrow points at the implantation. The second arrow, the red and the blue, point at the explantation time of the device, and you can see the serum creatinine and her serum lactate going down very rapidly. Similar was true with her AST and ALT, and you can see that the start of the nadir or the top level of LFTs probably happens somewhere around the 72-hour mark, and then the recovery happens, probably the recovery of the hepatocytes themselves. So this lady was explanted at, I don't know, day, whatever that was, 10 or something like that, or 8. And had gone home and is actually doing quite well. And this is actually the case that I had already told you about quickly, so I'm not going to dwell into it. But this demonstrates that sometimes you really actually get lucky in terms of selecting your device. The plan here was to try a univentricular system, and then if it, in an hour or two, didn't demonstrate improvement of hemodynamic parameters, that we would end up on a biventricular support. And at that time, the only thing that we had was either that we convert her to ECMO or that we add in a centromag RVAD. And I think probably had we gone there with either of these devices, she probably would not have survived, considering the fact that she was quite hypocoagulable and had an element of DIC/shock from her failing liver. So I think we really chose the device correctly, whether by good clinical judgment or luck, but it most certainly also demonstrated the benefit of offloading the ventricle, one ventricle to benefit the function of the other ventricle. So in this case, we probably allowed for some extra filling of the RV by simply draining the LV and allowing for the septal shift into the LV and allowing for the higher filling pressures of the RV without actually causing more of an RV limitation that she had than what she had come in with. Any questions?
Probably a good time to have questions from the room for Gordon's talk or any talks So it's probably time for questions from the room for Gordon's talk, for the cases, or for the talks you heard before. So there's one question here.
Thanks very much for a great afternoon, guys. I'm Kathy Cowles, interventional cardiologist from Halifax. I thought these two cases, two of the three cases that you did, actually demonstrate something that we're seeing a lot in our center, and I think we are all across the world seeing more and more cases of spontaneous coronary artery dissection, or SCAD. I agree with Vlad that your other lady probably was that too, and I think probably it's the troponinitis that is actually bringing some of these young people to our attention, and we're cathing them, young people with fleeting chest pain and funny circumstances. They get a little troponin bump, and we're now cathing them, and we're seeing more and more of the dissections. They're sometimes quite difficult to see, and even with angiography, I think we've previously written some of them off as normal, but when you look back, they really aren't. And they do exactly what you say. You touch them with a catheter, and you induce more harm. And so the best treatment is to do as little as possible, but if they're presenting with a STEMI or otherwise, you have no choice but to do what you can to save the heart. There is a whole group of people in Canada and the US that are studying this and looking into it, and now we have the Canadian Registry of SCAD that a lot of centers are participating in, and it does seem a lot of them are turning out to be fibromuscular dysplasia and not just your typical young person with hormonal shift, but we're seeing it in some older folks as well. So just last night in our emergency room, young person with actually pregnant with a little bit of chest pain and troponin. We'll find out what happens to her. But I think we're just going to see more and more of it, and it needs a lot of research.
Thank you very much. Nice comments. I appreciate it.
Just a comment, just leads to a very nice presentation, by the way. I just got, I have a fellow who's working on our experience, started in January 16 of all ECMOs and Impella, and we have 51 patients so far. So it's quite a good experience with mixing chips and shock. What we can say as a big picture is that when support devices are being used for chip, outcomes are much better than when they're done in shock, but that's expected. I think we're still using a lot the Impella in shock the old way. We're not doing it enough, early enough, like the Michigan is doing. You know, you might be aware of the data from Bill O'Neill showing that he's able to show survival rates of about 80% in shock patient, which is quite amazing. It's been presented at ACC 17 this year. In a selected group of patients, about 30, 35, and he compared to the other group. And they could show that with early on, putting the Impella can actually have a huge impact. And in the meantime, in Quebec, we're sort of focusing on, let's try to find a solution to decrease by 5 minutes door to balloon, where it's not going to change any survival, and it's a bit driving me sad to be sort of looking, trying to answer questions from the 90s, where people don't have a network to treat the shock patient. You can be in shock, but you can present yourself to Maisonneuve, which don't have a support system. It's like, so why aren't we more integrated in taking these patients? Because who died? The guy is in KILIP 1 presenting with an inferior MI? No way. Even if you decrease his door-to-balloon time by 20 minutes, you're not going to change a single digit of his mortality. What makes a difference is to take care of the shock patient the right way. But because it's costly, people don't want to see it. But the reality is that we have to organize ourselves and be strong as physicians and say, this is ridiculous. We got to be counting body bags. This is really what counts.
Stéphane, can you comment on the Bill O'Neill's data in terms of door to device, what was it like? Do you remember?
They were extremely fast. They were like, yeah. If you have any, do you have any? You have the answer?
Well, I don't have the answer. I just want to comment on it. I think Bill's data, and that's actually U.S. Bella Registry. It's not Michigan data, right?
Yeah.
It's U.S. Bella Registry. It's retrospective. So whereas it's very nice data and it's suggestive that there might be a benefit, but that's all it can do. It can't really prove that there's a benefit. There's no cause effect there, right? It could just as easily be that the patients who are given the Impella at the beginning are, have
Less
favorable
sick,
characteristics,
yeah.
and that
but
you're
it's
not
comparator group.
you're not necessarily capturing in a retrospective database. And yes, he's compared them to patients who had the Impella deployed afterwards, but my whole point is that you might actually be deploying the Impella in less sick patients and patients who are better candidates for an Impella. It could also be that those patients who have the Impella deployed earlier are sicker because they need it, so they got it because they needed it, but we just don't know.
Yeah, but that's innovation. That's it.
And we
innovation.
absolutely
That's
need
innovation.
we absolutely need a randomized trial.
You're right. You're
Yeah.
totally right. But that's innovation. That's why we should be trying to aim at trying to change. The old way we've been doing things, and as you beautifully showed, with meds and everything, is like the more we grow on meds, the more we make them so sick that we just are chasing our tail afterward. And the thing is that we're restricted. We're in a different ball game than the Americans. They get reimbursed $43K for each Impella implanted. So therefore, their administrator are coming to them, to the physician, and say, "Why didn't you put an Impella?" Whereas us, if we put an Impella, we got an administrator coming to us and say, "Why did you do? Why did you put it?" So we were completely living in a different environment, and we all have to understand it. But the truth must be somewhere in between. I don't think that the Americans have completely gone and doing the wrong thing. I think they have the resource, they are able to do it, and they are sort of at the front line, but we are extremely lagging behind.
I think they've gone crazy.
So speaking
I have a question for the audience. I think sometimes it's relatively easy to diagnose a STEMI, but to diagnose cardiogenic shock or any shock is more difficult. It's more gray than black and white, and the door to diagnosis is probably where we should or we could make the biggest difference at low cost. Once we have shock written somewhere in the chart, resource starts to happen and people get mobilized. But we oftentimes have that patient that's on 10 or 20 of Levofed that's in the corner there. He had his PCI and nobody's asking anything from him, but that's a shock patient that's not necessarily flagged, and that's where we could make the biggest leaps forward from my standpoint.
So we have a question in the audience, and then we'll come back to the panel. Please go ahead.
My name is Charles Peniston. I'm a heart surgeon in South Lake, Newmarket, Ontario. I'm curious, which centers in Quebec have access to VADs or use VADs or Impellas, VADs? Are they all academic centers, or are there any other centers? And this is a huge province. It's the biggest province of the country. So
there's long-term VADs and short-term VADs. There's 3 centers in the province, 2 in Montreal, 1 in Quebec with long-term VADs. And there's a larger number of centers with ECMO, 10 adult cardiac centers with ECMO. And then other short-term univentricular VADs are somewhere in between 3 and 10, depending on which device.
And are they centers that have heart surgery or
All of them.
cardiology? Yes.
Yeah.
All of them have both interventional and cardiac surgery.
Yes. Thank you.
So I want to ask a question that relates to Stéphane's comments. It appears to me, my understanding is that Ontario is restricting the use of assist device to ECMOs only. So is that correct?
They're not funding anything else, no.
Okay, so
they're not funding the Impella, they're not funding the Tandem
Okay, so
Heart.
if it allows you to do more cases as requested by Stéphane, is it a good decision or a bad decision? So is it a sufficiently good device to bail you out of any situation, or should we pay more, do fewer, but use more specific device? Sometimes you can nail a screw with a hammer, but it's not necessarily the ideal.
So, yeah, I mean, it's a good question. I don't think we really know the answer. I mean, if we get a mortality rate in shock of 40%, we're happy, but we shouldn't be happy, right? That's 40% mortality. We now have access to both the Impella and the tandem heart, and of course, not everybody can deploy a tandem heart because you need transeptal skills. Not all of us have them, so it's kind of a complex process of getting all the right people in place all at the same time. We haven't done one in shock yet. We've had experience now in high-risk PCI, and it's worked well. But that may be a better device than an Impella CP for cardiac output. But the Impella CP, of course, is much easier to deploy. And the Impella 5, generally, in our hands, needs a surgeon to do a cut down. So it's a complicated question. I don't know whether fewer patients should get it. I think we don't indiscriminately deploy these devices in Canada like they do in the US. That's my concern about the data, is that they put what I've seen at meetings, they put the Impella where none of us here
would go
would
first.
put an
We would
Impella.
wait a little more, yeah.
Yeah,
So that makes the results look better.
right.
Selection bias to start with.
Well, I think the pendulum in the States is completely one way. The pendulum in Canada has swung too far the other way. I think, and I voice the same concerns as Stefan did, that we are, number one, not aggressive enough, and number two, we are not recognizing that some of the cost can actually be cut by implementing these or implanting these devices early, and that we're doing probably a bad job in terms of supporting these patients with the full support with what they need. I think we're underutilizing Impella 5.0 over the Impella CP at least in our institution because of the syndrome of inconvenience. There is sometimes no surgeon present, or we put this device in and we pray and the device is not enough, and then we swell until we get well and it's over the following day. So I think we just need to look at where we are, and I think we need to sit down and look at this from both the financial and academic and the outcome perspective, and then put together some set of guidelines.
Yeah, I think because of the pressures of our administrators, we do tend to put them in too late. I see that. I think we're getting a little bit better, but especially initially we were putting them in very, almost non-viable patients when really the balloon pump wasn't working and nothing else was working. And metabolically they were horrible. I think we're getting a little bit better, but I think we still don't have it right because of funding pressures.
So
We probably have time for one more question. And then
Yeah,
we'll-
hi, Mohamed Nusser, I'm from Montreal Heart. I really like the comment from Gordon in his presentation in pertinence to the ECMO, that it's not a good choice when you want to offload the LV and when you have a monoventricular problem, and physiologically it makes sense. I just wanted to hear from the panel, each one of you, like what your choice would be, and would you choose the ECMO first, or why is it so commonly more used than the Impella? We use much less of an Impella than the ECMO, despite that it makes more sense. Thanks.
Okay, so we're going to restrict this for biventricular failure or Mo, you want discussion on biventricular failure or univentricular failure?
Mainly in the context of ischemia and infarcts. So monoventricular.
In ischemia and infarct, univentricular failure, what can help is if you are courageous enough, you can do a right heart catheterization, assess whether your right heart is working properly, but most of the cases, unless it's a proximal right, I think you should be able to get away with the left-sided SS device. That's my opinion.
Yes, I agree with Marc. I think there's a couple situations, either isolated RV failure or mostly isolated RV failure, isolated LV failure, biventricular failure, and biV failure with systemic repercussions. When you need to resuscitate periphery because of renal injury, because of liver failure, that's when I think we need ECMO. And the reason why we use that many ECMOs is that that's when the patients get referred. they get referred when they have organ failure that is deteriorating. And we're using ECMO because we have to deliver a normal cardiac output and a supranormal cardiac output for organs that have to recover. So that's why we're going all the way to end of the line treatment. But 6 hours earlier, maybe just an Impella CP or bigger could have done the work. So maybe in a couple of years, we'll be earlier in the process, and we'll put more univentricular supports.
It's just still where, you know, the mechanical circulatory support service in the majority of our centers is being mistaken for the resurrection service. So we're getting late referrals, and, you know, patients are so too far gone that the only thing you can offer them is ECMO because nothing else is functioning. So, you know, most of the time, I actually refuse patients for ECMO support, saying that this is beyond any sort of mechanical circulatory treatment capabilities. I mean, I advocate the correct therapy for correct pathophysiology, but unfortunately, in some cases, that's not. It's just not feasible because we have gone so far beyond from univentricular failure or you know, univentricular with a marginal RV failure, for example, where we would get away with offloading of the LV because that is actually the inciting pathophysiologic problem here. But unfortunately, we go so far that now the patient is in liver collapse, no longer requires 5 liters of flow, but rather 8. So now you're stuck with something that can deliver it. So you either put them on Centrimag, which is a surgical procedure and can deliver up to 10 liters, or you go with the lesser of the two evils and you put the patient on ECMO.
The better question is, in STEMIs, VAD or Revasc first? Vlad, what do you think?
I think STEMI and shock, we don't have the data. I think we have Bill O'Neill's suggestion that VAD first, and I would go with an assist device first before revascularization. And for no other reason, I think that I mean, I'm sure we've all seen it, the huge reperfusion injury.
Yep.
You know, the arrhythmias, the further need for pressors and inotropes after you actually open the artery in a shock patient, which is I think when they need it. They need that support then. I think we need to do that study.
Anytime.
Very nice. So that will end our session tonight. Thank you very much to all the, pardon me?
Yep.
Thank you very much to all the panelists, the great talks. Thank you for the audience, and fill up your evaluations, please, and we'll see you tomorrow. Thank you.